Good morning, friends. This is the subsequent lecture of continuity in breast cancer management. So, precisely hitting the medical oncology part under the umbrella of molecular aspect of a breast cancer. Myself, Major Dr. M.K. Beg, Associate Professor, Radiation Oncology, JP Institute, Kanpur, Uttar Pradesh Government. The few of the state lines for a breast cancer. Let me say that we have given a pumped a thousand of chemotherapy to the thousand of breast cancer patients without knowing the ER/PR status, HER2 new status, Ki67 indexing, VGEF receptor status. And they say about 2 decades back, when the molecular oncology was not developed, thanks to the pathology and a molecular oncologist who designed such a research and a development that the entire management of breast cancer is now changed in form of a chemotherapy. So, few of the straight lines for breast cancer, the overall survival for metastatic breast cancer is 18 to 24 months. Metastasis do response to the chemotherapy and hormone therapy, but radiation oncology do have a very important role for a quick response of that metastasis, whether it is compressing the spinal cord or the brain stem or the brain metastasis. The majority of breast cancer metastasis do occur within the 5 years of a diagnosis of primary site. The size of a primary tumor of a breast cancer do have an impact on the median interval of distant metastasis. Say about size 1 to 2.5 centimeter, distant mets 3.5 years. If a size is more than 8 centimeter, primary size of a tumor, this period bring down to the 4 month. Node is also having a impact on the metastasis of a breast cancer patient. Node negative patient do develop a metastasis in the 5 to 6 years of period. But this period cut down when the node is positive, axillary lymph node positive. These periods come down, so the distant metastasis chances of developing within 2.5 years. So, to understand the molecular oncology, we should understand the anatomy part of breast. There are luminal cells line the apical surface of a normal breast duct and have a secretory properties. Most of the breast cancers arise from luminal cells and are heterogeneous in their expression of hormone receptors and HER2 expressions. Heterogeneous means so not all the cells of a luminal express the HER2 or an ER/PR status. So you see here in this figure that luminal cells and then basal cell myoepithelial cells. So the luminal cells is just overlying the duct, lumen of a duct, and outer to that is myoepithelial cells or basal cells. The basal cells are located in the lower part of epithelium directly above the basement membrane, and the basal cells are usually configured like a pyramid within the basement membrane of a bottom, the top pointing toward the surface of epithelium. You can see here in this figure the breast anatomy in the luminal cells, and inside there is a lumen, and an outer surface is a basal or myoepithelial cells, and both are having luminal and basal myoepithelial cells having a different receptors in their content. So now, keeping these things in mind, let us hit on the immunohistochemistry part. Immunohistochemistry is used to characterize the intracellular protein or various cell surface antigens in the primary or metastatic tissues, broadly speaking. And an individual marker or more often a panel of various markers Example proteins, marker as well as surface markers can be used to characterize the various detail about the tumor characteristics. The role of immunohistochemistry in breast cancer to classify the breast cancer subtypes, confirm the tissue of origin, and distinguish the metastatic from the primary tumor. We can decide on the basis of immunohistochemistry whether it is a metastatic or a primary. Provide the additional information which may be important for prognosis, predicting the response to the chemotherapy and hormone therapy, and furthermore evaluating the residual tumor post-treatment status after the completion of a treatment. So these are the vital role of immunohistochemistry, which tells you about the status of a disease. The biological characteristics of the tumors are used to estimate the prognosis and select appropriate systemic therapy for the patient for breast cancer. The advent of a molecular technology has incorporated a new biomarkers along with the immunohistochemical and various serum biomarkers to assess the response, prognosis, and prediction regarding the breast cancer outcome. So the breast cancer myoepithelial or basal cells marker are useful for helping to distinguish the benign lesion from a malignant lesion. The most common immunohistochemical breast cancer prognostic and therapeutic markers used, these are what we should look for in immunohistochemistry: estrogen receptor, progesterone receptor, human epidermal growth factor, Ki67 index, BCL2 as a marker of apoptosis, and never forget to assess the markers of angiogenesis. That is very, very vital in order to start the bevacizumab or anti-angiogenic drugs. So the diagnostic markers of immunohistochemistry can be used to identify the histological subtypes or molecular phenotypes. What are these? They are like a differential diagnosis of various types of breast cancer. Benign lesion versus a malignant lesion, and also distinguished between the carcinoma in situ and invasive carcinoma, and diagnosis and differentiation of microinvasion and its imitating lesions and confirming the breast as a primary site in a metastatic carcinoma. These are the various things which you find out by the help of immunohistochemistry status report. So that I've already told you the normal glandular breast tissue is composed of two different. One is the luminal cells, and second is the basal and myoepithelial cells. And luminal cells express the cytokeratin 7, 8, 18, 19, epithelial membrane antigen, estrogen receptor, progesterone receptors, and as well as HER2 new receptors also luminal cells express. But what you find out by the help of myoepithelial or basal cells, or special markers are smooth muscle actin, calponin, S100 protein, and P53 that you find out by the help of a myoepithelial cell receptor study. The myoepithelial cell markers, which I told you, smooth muscle actin, calponin, P53, P63. These myoepithelial markers are useful in helping by differentiating the invasive carcinoma from a benign lesion. Like invasive carcinoma always lack a myoepithelial layer that normally surrounds the benign breast glands. If a myoepithelial layer, the histopathology, you don't go in a immunohistochemistry, that you can confidently say that the tumor is not in situ, the tumor became invasive carcinoma of breast cancer. The P63, this protein 63 is a homologue of tumor protein 53. It is shown to express exclusively in a myoepithelial cells. It can be very useful for distinguish the benign versus The different benign lesion, you can sclerosing adenosis, radical scar, papillary lesion, and using P53, its nuclear localization and absence of staining in smooth muscles such as myofibroblast and blood vessels. That is provides the 100% specificity. So that is the relevance of P63, uh, which is usually expressed in the myoepithelial cells of a normal breast. So what about the carcinoma in situs in the breast carcinoma like lobular or ductal carcinoma in situ? So there are two important markers, the E-cathedrine and cytokeratin 8. It determined whether the carcinoma in situ is a lobular carcinoma or ductal carcinoma. Like immunohistochemistry, E-cathedrine is currently used to differentiate between two. Majority of ductal carcinoma in situ express cytoplasmic E-cathedrine, where most of the lobular carcinoma lack this E-cathedrine. So that if immunohistochemistry you don't get an E-cathedrine, that you suspicious of lobular carcinoma which is in situ, but if it is present, that is ductal carcinoma in situ. So identification of a different subtype of breast cancer. My dear friends, I just want to address you that you can't get a very um adventurous and then very beautifully designed pictures in my slides, but that is the, don't forget you are basically learning the breast cancer at a molecular level. You don't see it by naked eye, so you don't get figure as well. So analysis of identification of subtypes of breast cancer. So analysis of both adjuvant and neoadjuvant trials has shown that not all chemotherapeutic agents equally effective in a breast cancer patient. Therefore, further individualization of chemotherapy is, is a need of hour. The difference in the chemotherapy sensitivity to taxanes and anthracycline suggests there are significant differences across the disease subtypes, which we all know. So it's very boring lectures. Let us go to the. This is what. This is as. I'll take you to the Switzerland directly. This Switzerland is city of as a city in the Switzerland called Saint Gallen city. It's a very beautiful city. I think more you people, those who have not visited, may visit at your own expense. So, what is importance of this city? The 12th International Breast Cancer Conference held at this St. Gallen, Switzerland in March 2021, and the consensus collected that identified the four subtypes of breast cancer according to the estrogen, progesterone, HER2 receptors. That is the importance of St. Gallen, city of Switzerland. So the four subtypes were luminal A. The luminal A were ER, PR positive breast cancer. They are classified as a luminal A. The luminal B termed as a ER, PR positive, but HER2 positive as well. So that is luminal B and HER2 overexpression and a basal cell life. The expert panel of St. Gallen provided a systemic recommendation of a different subtypes, these subtypes. What was that? Like for a luminal A, endocrine therapy alone is sufficient, but for a luminal B, HER2 negative, endocrine plus cytotoxic chemotherapy is recommended. And cytotoxic chemotherapy, anti-HER2, that is, plus endocrine therapy for a luminal B, that those who are HER2 positive cancers, breast cancers. And then the second, the cytotoxic chemotherapy plus anti-HER2 for a HER2 positive non-luminal breast cancers. And for a triple negative breast cancer, the consensus says that only cytotoxic chemotherapy and now the further monoclonal antibodies can be used. So these slides, you go through that luminal A ER positive and PR positive, luminal B ER positive, PR positive, and HER2 positive, all three positive. ER, PR positive, HER2 negative, luminal A, HER2 new, ER negative, PR negative, HER2 positive, and a basal like ER negative, PR negative, HER2 negative, that has triple negative breast cancer, and cytokeratin 5 and 6 uh, positive. They are unclassified. So as of now, today, what we look for, what we expect from the molecular oncology by the test of immunohistochemistry, that we should look for ER status, PR status, HER2 new status, Ki67 index, proliferating index, tumor protein 53, BCL2, angiogenesis marker. And out of all these three, the P53 BCL2 is not very attractive and not being proved worthy. So that we should focus on ER, PR, HER2, Ki67, and angiogenesis marker. So the first scoring system counted the percentage of positive cells and ignoring the staining intensity. When we determine the proportion of positive stained cells, at least 1% is considered as a hormone treatable state. If you study these tumor cells and you found the 1% cells are hormone positive, that you must consider these at St. Gallen, by the St. Gallen breast cancer guidelines, that you consider for the hormone treatable state of this patient, this group of patients. So according to the International Breast Cancer Study Group scheme, which is the basis of most recent St. Gallen treatment guidelines, breast cancer is divided into two groups based on the percentage of positive cells, hormone positive cells, responsive 10% response, uncertain in 1 to 9%, and non-responsive 0%. I mean the hormone positive, if a 10% definite response, if 1 to 9% is positive, that's a response uncertain, but 0% is no response of a hormone treatment. So in other words, a threshold of 1% positive cells indicate the option for hormone therapy, that is, I've already told you, these guidelines were widely followed in many countries in Europe and the United States. But the further advancement made that, but may various trials is so that we are in a state that we can say that there seems to be not fully satisfactory and seems to be insufficient. So the new guidelines was given by National Surgical Adjuvant Breast and Bowel Project. But till now, we are practicing this St. Gallen guidelines. But now started looking for the new guidelines given by the NSABP protocols. In a patient with ductal carcinoma treated with a partial mastectomy and then irradiation, who received placebo or a tamoxifen for 5 years, showed a conclusive reduction in both ipsilateral and contralateral breast cancer adjuvant tamoxifen group. So that shows the importance of a tamoxifen hormone. Not even the malignant lesion, even the in situ status of a ductal carcinoma in situ. So HER2 new expression receptor marker, let us talk about this. It was one of the first oncology studies in a sample of invasive breast cancer, and usually it is identified in 20 to 40% of Indian breast cancer patients. This percentage comes down to the European countries is merely 10 to 20%. And this is very, very important marker. which further pushed the medical oncologists towards think of the more advanced chemotherapeutic drugs. Like if this marker is sensitive to herceptin, like trastuzumab, and also tells about that these group of patients are resistant to tamoxifen and they do not respond to the traditional CAF regime. So you have a paclitaxel and anthracycline based chemotherapy. Though the HER2 loop can be detected by various methods, but two currently approved methods are ISC and FISH, what is fluorescent in situ hybridization. But FISH is more costly test and a FISH prevalence is much more in compared to ISC because ISC evaluates the overexpression of receptor protein on the surface, but the FISH evaluate the status of HER2 new gene at the nucleus level. So one is working on the surface level, one is working on the nuclear level, that is FISH. So testing is difficult for a FISH. Majority of HER2 positive cancers, like HER2 protein overexpression due to result of gene amplification, thus both methods should be highly correlated. The FISH and ISC both should be correlated. The immunohistochemistry reaction for HER2 are scored by the HERCEP test. So what we should know while seeing the HER2 new report, that whether 0 and 1 plus score are considered to be negative. 2 plus is a weak positive. 3 plus is positive. So a positive HER2 result consists of a uniform intense membrane staining more than 30% of tumor cells. So which 3 plus is a pathologist states when there more than 30% of a tumor cells staining is positive, and weak positive or 2 plus cases should be tested for a gene amplification by FISH to further confirm the same. So again, I'll take you to the now to the Germany, city of Kiel. It's boring lecture. So you see this beautiful city of Germany and this city of Kiel of Germany. Why it is I'm telling you, because the marker of a proliferating index Ki67, the G, was discovered in this city. That's why the name of Ki67 on the city of Kiel, Germany, where this antibody was produced in the pathology department of university, 1983. So Ki is basically a non-histone protein and involved in the early stage of polymerase independent ribosomal RNA synthesis is predicting and prognostic marker in the breast multiple cancers, including the breast cancer, and has been exclusively studied. The Ki level is above 10 to 14% of the breast cancer patients are defined as a high-risk patients. According to the same Gallen guidelines, the Ki index is useful for selecting the patient with a hormone receptor positive breast cancer for the addition of a chemotherapy with endocrine therapy. Thus, the breast cancer classifies according to the Ki leveling index, like 15% is a low risk. If a Ki level 16 to 30%, the intermediate, and if a Ki index is over 30%, the high risk. The Ki expression was associated with additional independent prognostic parameter for disease-free survival and overall survival in breast cancer patients. So that is the importance of Ki indexing regarding the breast tumor. It is known that the patients with triple negative breast cancer have a poor survival despite their high response rate to the neoadjuvant chemotherapy, and those with a high Ki67 have a more aggressive clinical features. The BCL2P53 prevalence is not being proved worthy in the molecular oncology of breast cancer. So that we'll be skipping this slide. I'll tell you about the P53 genetic status in a breast cancer. that P53 positive is stated with regard to early breast cancer, that some scientists have reported a P53 mutation has no influence on the outcome, and therefore the value of P53 status is too weak to recommend as a routine marker in clinical practice. And we traditionally know the P53 tumor, a P53 gene is I mean, apoptotic gene, and anti-apoptotic gene is BCL2. BCL means, what is BCL2 stands? Because this gene was discovered in the B cell lymphoma first. So that is why called BCL2. So now I'll be taking the last immunohistochemistry marker, that is the angiogenesis marker. The commonly used method to determine the tumor angiogenesis in a breast cancer or other cancers is counting the intratumoral blood vessels, and which is stained with a factor VIII related antigen or antibodies CD31 and CD34 using a light microscopy. What is CD? CD31 is what, compact disc something? No, it is in terms of the pathology, is cluster of differentiation. So CD is a cluster of differentiation. So NT-CD31 and NT-CD34 used for the assessment of angiogenesis marker for deciding the new line of treatment, those who have a positive angiogenesis marker. So counting newly formed stained microvessels is useful tool in early detection of metastatic potential and selecting the group of a patient, those who have anti-angiogenic drugs might be beneficial. So reactivity level of CD34 antigen was assessed by immunohistochemistry in all types of invasive ductal breast cancer, and its level seems to be useful prediction for development of a local lymph node metastasis and indicate the benefit of angiogenesis treatment. If you are providing a patient with a costly drug, you should get a test done. Like a bevacizumab prescribing, at least you get the test of for this uh, angiogenesis done by the help of ISC markers. So anti-angiogenic drugs have been approved recently for many advanced cancer, including the breast cancer, and the drugs alone with a combination of chemotherapy are able to improve overall survival and progression-free survival in the cancer patients. That's authentic data we have. The most of the biological and clinical activity of anti-angiogenic drugs like bevacizumab currently approved for the cancer therapy against vascular endothelial growth factor. So vascular endothelial growth factor system is a part of the platelet-derived growth factor gene family. And we have a different type of a VGRF, vascular endothelial growth factor receptor 1 to receptor 2 for vascular endothelial A, a very potent angiogenic growth factor. So what is the take-home message for this lecture? The immunohistochemistry has an integral part for breast cancer management as an important part of pathology laboratory. It is more mature technology and accessible to majority of pathology laboratory in European countries, but same is on contrary is lacking behind in India. ISC can be used for diagnostic of tissues, estimating the prognosis and predicting the response, especially for the chemotherapy and hormone therapy. The best approach in the use of immunohistochemistry marker is to combine them with examination of a standard panel of markers. Just a standard panel of markers, not in a one by one marker, so that you get an assessment. The reactivity of steroid receptor was observed to decreasing with increasing grade, and also we should remember the grade 3 tumor were more receptor status negative as compared to grade 1 and grade 2. This shows the same inverse relation between the receptor status and increasing the tumor grade. Grade 2 tumor were more receptor status negative as compared to grade 1 and a grade 2. That showed the same inverse relation. So thank you all the boys and girls for patient hearing of this boring lecture. But don't forget, I have taken you from Switzerland to the Germany. and that the story begins not from here. The story begins from Italy, the Milan, the Belladonna regime, that is CMF regime, first developed there, and then you went to the St. Gallen, Switzerland, where the very, very new guidelines is being developed. So these are the, I mean, this is the sheer contribution of eminent pathologists around us, molecular oncologists. They are actually asset for a medical oncologist to design and pump very costly drugs to the most suitable and appropriate patients. Thank you very much.